is really the pioneer, and I'm sure people will they will direct, and with the help of government and state government, I think there is a lot of awareness. I've had discussion with people in Department of Biotechnology. As you know, they have invested heavily, and Wellcome Trust from UK, they have got a joint enterprise called Wellcome DBT. So things are quite positive in some respect. It's up to you people to take advantage of it. So I think with this note, I will stop and wish you all the best for this conference. And I'm sure we will have more things to come, and from you, many cases and many new discoveries will follow. So all the best. Thank you.
Thank you, sir, for the wonderful words. May I please request Dr. Shubha Patki ma'am, President of the Society of Indian Academy of Medical Genetics, to say a few words.
A very good morning to you all. Respected Dr. I.C. Verma, Dr. Dhavendra Kumar, Dr. Sanjeev Mishra, dignitaries on the dais and in the audience, and my friends. It's really an exciting moment for me, and probably for Dr. I.C. Verma sir also, because the vision of these two people, Dr. Verma sir and my teacher, Dr. S.S. Agrawal, and their efforts which started more than 3 decades ago, have led and ushered Indian medical science and medical people into the era of molecular genetics or molecular medicine, because over these last 2-3 decades, their efforts have led to the training of medical geneticists all over India. Many more centers have established, and it's really an important time that the like-minded people involved in the area of medical genetics have formed this society and this second conference which we are holding in Jodhpur. And I really thank Dr. Soni and Dr. Kuldeep for this occasion and making this conference come into the reality. I'm very happy to see so many participants, especially many young faces in the audience. This is very important. Medical genetics is a super specialty, as by training we say. But the other aspect of medical genetics is that it is a part of biology and part of every medical specialty. So anybody, any clinician, whether he is an ophthalmologist or an obstetrician or pediatrician, or as Dr. Sanjeev said, oncologist, everybody has to know the concepts of basic genetics and molecular genetics. Without that, nobody will be able to practice in this 21st century. So our aim of Indian Academy of Medical Genetics is not only to do a very high, so-called hi-fi medical genomics, but we want to reach all clinicians at any stage of their career, whether it's MBBS student, postgraduate students, or those who are already practicing doctors or college professors. So we want may create awareness so that they identify patients with possible genetic etiology and look at those patients with genetics perspective. So it's not that medical geneticists will take care of every patient. Every clinician will have to identify patients with genetic disorder, draw their pedigrees, order their genetic investigations, including now exome sequencing, and appropriately manage those patients with modern treatments as well as provide them genetic counseling. So all this will not be possible unless every clinician is aware of these latest developments in the field of medical genetics. And I'm very happy that through this conference, we have been able to reach many more clinicians as well as medical students in Jodhpur and all over the country. And I'm sure this program, which is very meticulously planned by Dr. Kuldeep and Dr. Soni, will give you overview of medical genetics and the current scenario in India and everywhere in the world. And I'm very happy that previously whatever we could do in India, which was far away from what we were reading in the science. But nowadays, whatever can be done for any patient in US, same things can be done in India. And really at this point, unless all the clinicians are aware about medical genetics, these fruits of latest developments in the area will not reach in Indian patients. So I'm very happy and thankful for all of you who have registered for this conference, and I'm sure that this conference will be very helpful to you immediately as well as in long run of your medical career. Thank you very much.
Thank you, ma'am, for your encouraging words. May I please request Dr. Sanjeev Mishra, sir, to present a memento to our chief guest, Dr. Dhavendra Kumar. Thank you, sir. May I please request Dr. Sanjeev Mishra, sir, to present a memento to Dr. I.C. Verma, sir. May I again request Dr. Sanjeev Mishra, sir, to present a memento to Dr. Shubha Fatke, ma'am. May I please request May I please request Dr. Anil Jalan, sir, to present a memento to our director, Dr. Sanjeev Mishra, sir. May I please request Dr. Bhattacharya, sir, to present a memento to Dr. Sanjeev Mishra, our respected director, sir. May I please request Dr. Ratnapuri, ma'am, to present a bouquet to Dr. Anurag Singh, sir. Momento. Thank you, ma'am. It is my utmost privilege to call upon respected Dr. I.C. Verma, sir, to present the keynote address.
ये टॉक लोड करनी लोड करिए ये किसकी ये डबल एफ जोधपुर जोधपुर है डबल एफ जोधपुर में डबल एफ हाँ ये हाँ ये करो चलो ऑन कर दो इसको ये निकाल दो मेरे को ये निकाल दो ये आया नहीं भाई ठीक है Dr. Misra, Dr. Davendra Kumar, Dr. Phadke, Dr. Kuldeep Singh, Dr. Soni. It's an honor and a privilege for me to be invited to give a keynote address for this very important conference. I'm also happy that I'm here in this AIIMS Jodhpur, it's a new institute with a lot of promise. Dr. Mishra, of course, belongs to a specialty where genetics has contributed a great deal. And I'm very happy that Kuldeep Singh, who is a trained medical geneticist, has also already started a genetic clinic. So I hope Dr. Mishra will continue to give him support to finally set up a department. So the topic for today is medical genetic practice in India. So this is the 150th anniversary of Mendel's presentation to the Brunn National Historical Society of his observations on the plants. So this is a picture I took of the monastery when we had a conference there. So on breeding he made it two laws, alleles segregate and non-alleles assort. But we'll not go further into this. But for 50 years, nobody bothered about these observations. So it was left to Bateson, who actually coined the word genetics, to rediscover this and market the law. So it's not enough to make a model, to make your, I have ideas, but you have to market the idea. Because for 50 years, they lay in an obscure journal and nobody bothered about it. So we move now to modern Mendel, McCusick. And he said, genetics is to medicine what the periodic table is to the physical sciences. Eric Lendl, who was one of the pioneers of starting the Human Genome Project, he said Human Genome Project is to biology what the periodic table is to chemistry. And this is the man who made the periodic table, Mendeleev. So all these symbols of chemistry, very important. So as Dr. Mishra mentioned, genetics should actually be, and Dr. Phadke also mentioned this, is the center of all the specialties. But unfortunately, it has not been translated into a medical curriculum in India in a proper way. I hope the institute here, the new institute, should have enough genetics, because all the textbooks, if you look, the recent information, there's a lot of genetics in them. Most doctors have the impression that genetics is concerned with rare disorders and there is no treatment for them. And that's why it's sort of been neglected. But therapy is available for many genetic disorders. So when I started as a fellow at Mass General Hospital in Boston, so we were only giving counseling regarding risk of recurrence. But now in India, the role of a genetic counselor is not only to counsel about risk, but in fact he has to first make the diagnosis. He has to counsel the patient, he has to treat the patient, and he has to prevent disease in future offspring. So medical geneticists have to deal with all problems of the patient. What do you want to do? You want to? Let me do it. So medical geneticists have to deal with all problems of the patient related to genetic disorders. So this is a different role than you have in the Western countries, because there are so many specialists. Here we have to do diagnosis. There mostly patient will come with the diagnosis to the genetic clinic. Now the challenge in India, of course, is the variety of disorders. A point that was mentioned by Dr. Davendra Kumar, starting from prenatal diagnosis, metabolic disorders, chromosomal disorders, infertility, skeletal dysplasias. So there is no dearth of patients as such in India. So high burden of genetic disease. There are many cases to study. And you see Dr. Ashwin and Dr. Girisha, they could collect a large number of patients and publish their rotational studies, which are some of the largest in the world. So which country you find, you will have 34,000 cases of Down syndrome born every year. So this is the immense challenge that we have to somehow reduce and manage them. So this huge burden, you have got to treat those we can. And then we have to reduce the burden by preventive strategies, counseling, carrier screening, preventing marriage between carriers, prenatal diagnosis, pre-implantation diagnosis. But the most important is for all this is to make an accurate diagnosis. Unless you make an accurate diagnosis, you cannot move further. You can do it on clinical many times, but we often have to employ laboratory tests. But in spite of the best clinical and investigational efforts, with the standard technologies, we know that no diagnosis is reached in 40 to 50% of the cases that we see in our practice. Why we need to make a diagnosis? Because it ends a diagnostic odyssey. People spend lakhs of rupees in investigation, microarrays, MRIs, to come to a diagnosis, and still they don't find. It reduces medical expenditure. It gives you potential treatment. If you know the diagnosis, you can look for treatment. You can prevent the disease in future offspring, and it advances the knowledge about common disorders also. And you use these technologies, cytogenetic microarrays, biochemical enzyme assays, tandem spectrometry, and the Sanger sequencing, and next-gen sequencing, and the multi-TOF. So these are the traditional tests that we've been using, the gel-based PCR, Sanger sequencing, and over the years we've carried out a lot of studies. Thalassemia obviously was the commonest, and Duchenne next common, and spinal muscular atrophy the third. So when the others are there, in decreasing order. And continuously the number is increasing. We used to do 20 tests in 1997, and now we do more than 400. Now, the next-gen sequencing technology, when the Human Genome Project was completed, it cost $2.7 billion, and it took 6 to 8 years. Now, the same thing can be done in $2,000 to $4,000 and takes about 1 to 3 days. No other commodity, there has been a reduction, 500,000 reduction in the cost. So much cheaper now it has become. So it's not surprising that the next generation sequencing is considered to be the most powerful diagnostic tool developed in medicine since the radiogram. You do X-ray and discovered by Marie Curie. Its value and utility in clinical medicine will be enormous. Anyway, so the next-gen sequencing permits rapid sequencing of large amounts of DNA. So you can do target sequencing, you only select some. Then you can do whole exome sequencing, which means 1% of the genome can be sequenced to give you a lot of information. These are the exomes which code for proteins. You can also do whole genome sequencing. You include introns also, because in some cases you can't find the answer here, then you have to go here. And as you go further this way, it is increasing cost and complexities of interpretation. Let me just. So, this family, we saw this family about a month back from Iraq, consanguineous family from Iraq. He's a 14-year-old boy and some 16-year-old girl, and these are some 19 and 23. So they were short, underdeveloped sexual characters, delayed bone age, but normal intellect. First I thought maybe growth hormone deficient, but when we did the test, we found that low levels of growth hormone, testosterone, FSH, LH, so it was hypogonadotropic hypogonadism. So it did not need rocket science to diagnose whether it's a combined pituitary hormone deficiency. So there are 7 genes which can cause this. By a process of elimination, that what are the features of the various gene, so we found the commonest gene which causes this is POP1. So we did sequencing of the homologous large deletion. The whole gene was deleted in this array, and this is causing the problem. So if you have a gene which is not too big, you go single sequencing of that gene. The first, easiest, easy to interpret. So all large genes like DMD, if you don't find the deletion, you have to look for point mutation. You have like a neurofibromatosis, large gene, or you find tuberculosis, there are 2 genes. So we have to do cellular sequencing because the cost is, it reduces the cost. But there are some features like deafness, like CGD, congenital glycosation defects. So there are many genes here. And many times you cannot differentiate them on clinical features. So you do panel of genes. You do an NGS panel to diagnose which gene is involved and what is the mutation. For example, here, even little muscular dystrophy, 22 types. Autosomal dominant 7, recessive, and over 15. So 9 unrelated patients from the community. They usually become wheelchair bound by age 40 or 45. A gene panel for 12 genes was studied, and all these 9 patients, they were homologous. These 2 mutations caused all the problem. And it was confirmed there is a founder mutation. We have identified 8 mutations in the agarwals, which are all founder mutations. That means if they saw what happens is the benefit of this study. If any other patient comes to us with limb-girdle muscular dystrophy, first we look at the calpain gene. And we are right almost 90% of the time. And test is easy and is costly and is cheaper. If the symptom, if the features are non-specific, you cannot pinpoint any gene, you have to do whole exome sequencing. So here was a 40-year-old man, he had a GI infection, he was given tretinoin and developed a reaction. So given steroids. After 2 days, he developed weakness of all his limbs and which improved after testing. So he got episodic attacks of this muscle weakness and some sweating and bloating in the abdomen. He had been to at least 15 to 20 doctors, neurologists, metabolic physicians, and I myself was scratching my head what this disease is. So, but I noticed one thing, that this doctor had a similar problem. So I said this must be genetic because the doctor is involved. So we went and did a whole exome sequencing. And we found that there was a missense mutation in the DCTN1 gene. So we are studying this further, and it was the mutation was present in the father and the daughter, and not in the wife. So this sort of collaborated that this is causing the problem. So our experience with 300 patients with NGS is summarized here. We have done 101 for exome sequencing and 199 for panel sequencing. So if there's a large gene, we also do panel, and if there is a genetic heterogeneity, that means there are many genes causing the same problem. So this is the data for the exome sequencing. So there is a term called clinical exome. We had an American visitor, he said, I have heard this term only in India, clinical exome. Because we have the exome, the clinical exome is some companies have introduced this, the total exome is like 20,000 genes. Clinical exome, they study about 2,000 to 4,000 genes, less. So it's cheaper. So we did this clinical exome in some, and so these are the neurological, neuromuscular, metabolic, and these are the other distributions. So the results were this, that we were able to establish a diagnosis in about 55%. These are 22% in the clinical exome, in the exome, and 33% in the clinical exome. There are some, of course, no diagnosis, and some is still ongoing. In the world, mostly the yield of this whole exome is 25 to 30%. So we had more because we had this clinical exome, where we had only large genes to study. So whole exome sequencing. So this man called Kingsmore, he is my current hero. He established a technique that in 50 hours, he will sequence the whole genome. Rapid sequencing, annotation. It's neonate at 1 month, developmental regression and seizures.